Welcome to the October 2024 Annual Retiree Health Fair event. This video is an educational brief on advanced care planning forms that you'll be able to legalize today. Your presenters are all captains in the United States Army, which includes myself, Dr. Garcia, and my colleagues Dr. Kanaram and Dr. Ramachandran. This is under the guidance of our geriatrician, retired Colonel Dr. Salinas. For the purposes of our presentation, advanced care planning will be referred to as ACP. A few reasons to consider ACP. So it gives you control over your healthcare needs and allows you to communicate those when you're unable to. It ensures that your healthcare wishes are known and followed, and it can also give your loved ones peace of mind knowing that they acted in accordance with your medical wishes. The 3 ACP forms that are legally recognized in the state of Texas include the Medical Power of Attorney, which will be referred to as the MPOA throughout the presentation, the directives to physicians, surrogates, and friends, and the out-of-hospital do not resuscitate will be referred to as OOH DNR throughout the presentation. Once any of these forms have been completed, patients should ensure that copies are provided to the medical team, designated medical power of attorney, and estate planners. The OOH DNR form should also be maintained on your person in addition to a visible place in your home, such as your fridge. Texas offers patients 2 ways to complete these medical legal documents. The first way is to sign the forms under the supervision of a notary, or you can obtain 2 witness signatures. However, both must be older than 18, and one cannot be a healthcare clinician or employee, spouse, heir, or relative to the patient. Additionally, the OOH DNR does require your physician to also sign in 2 separate places.
I'm Dr. Ramachandran, and I will review information about the MPOA form. The MPOA document allows you to appoint people as an agent who will make medical decisions in the instance you are unable to communicate your personalized medical preferences or are deemed medically incapable of making informed decisions due to a cognitive or physical impairment. When your medical team is evaluating your medical decision-making capacity and the necessity to incorporate an agent into the decision-making process, a provider assesses your ability to understand the nature of your current medical problems, what the proposed treatment or other options could be, to include withdrawing or withholding treatment, appreciate the consequences of your intended medical decision, and communicate your decision. A good agent should be considered trustworthy, able to make difficult decisions under pressure, and know your end-of-life values, healthcare goals, and preferences, because the agent is prohibited from acting against your wishes and will have access to your medical records. Because the documents are highly customizable, it is important to know that Texas has a legally preset hierarchy of agents if an agent was not previously identified at the time of incapacitation. You have the option to include a first and second alternate agent in case your primary MPOA is unavailable, cannot be reached by medical personnel, or refuses to make decisions for you. The MPOA has a section in which you can place limitations on the decisions the MPOA can make for you. For example, if you are a Jehovah's Witness, you can state no blood products, which prevents the MPOA from making any decisions on blood products. You can designate an expiration date for this form. Otherwise, it will be valid indefinitely until you decide to change your power of attorney. Filling this MPOA form will revoke prior MPOA forms.
When an illness, injury, or disease progresses to a point that you are expected to die without life-sustaining treatment, your medical team will need to know and document your treatment preferences. If you're unable to communicate those preferences, then an advance directive allows us to decide which of the two end-of-life care models the team should pursue. The two avenues of patient care considered for end-of-life planning includes life-sustaining treatments that gives your medical team permission to provide compressive heart and lung resuscitations, electric shocks or medications to maintain vital stability. It also provides you with artificial life support through breathing machines, kidney replacement therapy, and artificial hydration and nutrition. Life-sustaining treatment, though, does not apply to hospice care. The alternative during end-of-life stages is to consider comfort care. This ultimately withholds all available life-sustaining treatment, allows patients to die as gently as possible with interventions such as pain medications and short-acting anti-anxiety medications. Comfort care also stipulates that medical procedures are only performed to maintain comfortability. In the instance you're unable to communicate your preferences, it is important to consider that end-of-life care evaluates irreversible and terminal conditions. An irreversible condition is considered an illness, injury, or disease that could be treated but never cured, such as early-stage heart, lung, or kidney disease, early stages of cancer, early stages of dementia, or conditions that can start as irreversible but progress to terminal. A terminal condition, however, is an illness, injury, or disease that cannot be cured by any medical standards, and death is predicted within the next 6 months. Examples of this include end-stage organ disease of heart, lung, or kidneys, terminal stage cancers, and advanced cognitive impairments such as Alzheimer's. Once you've selected your preferred end-of-life planning, you are then asked to consider other specific requests that could be medically indicated to maintain functionality of life or provide medical treatment for illnesses that did not directly result from an irreversible or terminal condition. Alternate medical treatments that can be documented as preferred or not preferred includes, but is not limited to, the use of IV antibiotics, invasive procedures that allow for a patient to have portions of their large colon rerouted to a collection bag that remains outside the abdomen. The best way to maintain hydration is ingestion by mouth. However, we can offer you IV hydration. Similarly, if you are unable to feed yourself and you are incapacitated, your family can consider giving you nutrients through your IV or having a surgically placed stomach tube readily available so that nutrition can be put directly into the stomach. The last form to review is the OOH DNR, which offers an additional communication for your end-of-life preferences. By signing this form and having it available, you agree that if you're found in natural death outside of a hospital inpatient admission setting, that you would not like emergency medical personnel to perform resuscitative efforts. Resuscitative efforts are automatically deployed within 10 seconds if you are found unresponsive and without a pulse or breathing, because this is considered natural death. The OOH DNR can provide patients with an avenue to die peacefully because what we do know is that the resuscitative efforts are not like the movies. In order to provide effective chest compressions, your chest will be compressed 2.4 inches into the sternum over your heart for 2-minute cycles with the intermittent use of electric shocks and medications to attempt recirculation of oxygen to your heart and brain. According to the American Red Cross, as of October 2024, they found the longer someone endures CPR, the more rib fractures they will sustain. 99% of patients will experience some form of lung injury. At a baseline, patients who are found in natural death outside of the hospital hover around an 8 to 10% survival rate, even with the resuscitative measures employed in an appropriate amount of time. At a baseline, patients who are found in natural death outside of the hospital have a 8 to 10% survival rate, even with resuscitative measures. And for every minute that a patient goes without CPR, the chances of survival decrease by 10%. Although this form will not apply if admitted, it's important to recognize that even when you're admitted and have quick access to resuscitation, the death rate is still 70%. In completing this form, if you were found in natural death while not admitted, you will not receive CPR, shocks to the heart, medications, artificial breathing, or airway maintenance, which will allow you to die in a natural manner. Although this form was discussed for education, the OOH DNR will not be available for signatures during the event. Lastly, we'd like to talk to you about the tips for talking about your ACP. It's significant and important to make your wishes known to not only your family, your agents, but also your healthcare team. Talk with your clinician about your advanced care planning. Especially for patients over the age of 65, this could be a dedicated annual visit. Your friends and family should know about your ACP, and it's important to talk about it using current events, media, or storylines from books, TVs, or movies to help the conversation start. Because this is a difficult topic, be prepared to have more than one conversation. Here's a set of QR codes that you can scan with your smartphone that provides information about advanced care planning and can give more context to certain situations. This concludes our presentation. Once you've finished watching this video, please fill out the post questionnaire and return them to a doc booth closest to you. There are doctors available at the doc booths who can provide more information or answer questions regarding your individualized advanced care planning.